Good evening and welcome to the NCNW Affordable Healthcare Webinar headed by the Health Equity Committee. If you have questions during the evening, you may put them in the Q&A. Be mindful we need to read them, or if you'd like to speak directly, you can raise your hand and we can see if we can accommodate you. At this time, I will turn this over to the co-chairs of the Health Equity Committee, Ms. Shara Denton and Dr. Angelia Elgin.
Good evening, everyone. Thank you, Johannes. I am Shara Denton, the chair of the National Health Equity Committee, and I also have my co-chair, Dr. Angelia Elgin, who's my co-chair, and she also chairs the COVID subcommittee of health equity. Thank you for joining us on this evening. On this evening, we want to introduce someone that some of you may already recognize from some previous events, but our speaker for tonight is Dr. Oliver Tate Brooks. He received his undergrad degree in biology from Morehouse College and his medical degree from Howard University College of Medicine. He's a past president of the National Medical Association, a board member of the California Immunization Coalition, and chairman of the Immunized LA Families Coalition. He's a member of the ACIP COVID-19 work group, discussing and making recommendations to the ACIP regarding COVID-19 vaccines. He has received numerous honors and awards, outstanding service to the community per the National Council of Negro Women, Long Beach, California, the Wall of Excellence for Medicine awardee for Long Beach 2016, Black History Month, and named one of the 2019 top Blacks in healthcare by blackdoctor.org. Dr. Brooks, thank you so much for joining us on this evening.
Happy to be here. Happy to be able to provide any information you may need that I have.
Well, thank you so much. We have a couple of questions to kind of start the conversation. And one of them being, how much progress have we made with affordable health care, and what does that future look like?
So the major step forward, obviously, was the signing of the Affordable Health Care Act under former President Obama. I believe that was 2012, 2013, I forget the year. But I was actually in Barbara Boxer's office at the time, and it was just, it felt the energy. So again, significant move there. Since then, despite attempts by other political forces to reduce or eliminate the ACA, it has stood firm. I would say that we still have some issues because there are some that fall in the gaps. Generally speaking, it's working class people who don't have health insurance, who would have to pay for it, who cannot afford it. And then some that are, I won't say indigent, but poor, but above poverty level, but really can't afford it. So overall, we made a great leap then, and I'd say we've been just kind of treading water since the signing of the ACA.
Well, with that being said, Dr. Oliver, you mentioned the above the poverty line. How does that correlate with, let's say, our maternal health?
All right, so it's a really good question. So in California, we have emergency coverage for women that are pregnant. It covers their pregnancy and post-pregnancy for actually up to a year here. And interestingly enough, when I am active with the NMA, but when I was more active as a president, we were pushing toward having that as a national standard. Woman can get emergency Medicaid, but it lasts for 3 months. Well, she has problems 4 months out from a pregnancy. So that has not passed on the national level. In terms of maternal health, often in states with poor coverage or for women that don't have good coverage, that is a category that seems to get a little more attention. So I think we are okay in that area. But again, the bottom line is what we really need is universal coverage, universal health care.
And with that being said, what can we do as a community to dispel these barriers of affordable health care?
So I think communicate. For one, there are these health exchanges where you can buy health insurance. And, it's mandated you have auto insurance. And as I think back to your initial question, that was a major change that diminished the Affordable Care Act because it was mandatory. And so that brought in a lot of individuals that were young and relatively healthy and made the whole pool of those being insured a little less expensive. I mean, if you only had drivers that had accidents, then insurance would be very expensive. So first of all, have these people considered are uninsured, have them look at the exchanges and consider, you may have to pay $250 a month for health insurance, but you're paying that or more for auto insurance, and your health is more important than your car. Secondarily, as it relates to being politically active, vote, period. But then when you vote for those that advocate for policies that are in your best interest. And be specific when you look at some people running for office. Is this person someone that would advocate for health policies relevant to me, to my community? They advocate for health policies that would be broader. They advocate for health policies that do look at the special circumstance of a pregnant person, and then that child that comes from that pregnancy. So that's what it comes down to. You make your mark with your vote, and we're a month away. So now is the time.
Thank you. And since we're still on the topic of maternal health, we know that there's been a lot of disagreements, I will say, with the recent Roe versus Wade decision from the Supreme Court. How do you think that decision has affected or will affect maternal or women's health in general when it comes to affordable health?
All right, so and it just makes me think slow. That's why I'm pausing. There's just so many ramifications to that.
Right.
So women, first of all, within the realms of normality, only women can get pregnant. Okay, so a lot of these decisions are being made by men. They have women involved, but this has separated a woman from her body for her right to choose. And I'm not saying that politically. I'm just saying that's just kind of what it did. So now there will theoretically be some unwanted pregnancies. A woman just got in a situation, a guy and a gal get together, the woman gets pregnant and the guy can walk away. It's just really that simple. That's why I think we need to understand that that's the way it works. So, they had a consensual relationship, she got pregnant, used birth control, it didn't work, didn't use birth control, whatever, it still always ends up being on the woman. So then you're gonna have unwanted pregnancies. So what do we do with those children in those situations? This question. Now, there will be those who didn't want to get an abortion. They may end up getting an illegal abortion. They may end up traveling to another state. All these things will put stress on the woman. So she has the abortion, then it's done. If for somehow she can't get it, there are studies that show that if you're in stress or under stress during a pregnancy, it can actually lead to not as good of an outcome of your pregnancy and of the outcome of the newborn. So it's all these barriers, all these obstacles where it should be smooth and easy. This is the most important time for this woman. She should, the guy should be, buying her roses and massaging her feet or something. Just taking good care of her to show the love for that she's carrying his child. It's not always a relationship like that, but still, I really believe that the Roe versus Wade decision has put all these stressors on the pregnancy. And with that, the one that has to bear it is the woman.
Right. Well, in your opinion, Dr. Oliver, what are the next healthcare priorities for African-American women, whether that be maternal health or mental health or whatever the case may be? What would you suggest are, in your opinion, the next steps for us as African-American women?
Right. So I think you mentioned mental health. So I think behavioral health is very important. I mentioned the stress. I'm trained as a pediatrician. So what I see those who bring the child in to the doctor, and I see those that support the family. 8 out of 10 of those that bring the child in to the doctor are women. And then when there are issues inside the family, it is the grandmothers that step in for the children. So I have the utmost respect for the grandmothers and the mothers. I love my fathers, and fathers do everything they can. But again, ultimately in human society, it falls on the woman often to be the primary caretaker for the family. So that leads to a lot of stress. So I would say that women who are feeling stressed should be able to get behavioral health support. Simple concept of therapy or counseling. I was having a conversation with someone, and a simple concept hit me that I had never thought of. You're supposed to go to the doctor every year to get a checkup, we call it, right? That's the doctor. I thought about the fact that it's probably reasonable to go every year to get a mental health checkup. There is no guideline that says women should get, breast cancer screening at 45 or 50, or you get a pap smear, or colon cancer screening. I think there should be a mental health evaluation every year, and you find it 33%, 1/3 of all of them would say, I need to see someone more than once a year. So I think behavioral health, and get the stigma out the African American community about behavioral health, going to see a therapist, and feeling comfortable with that being part of normalizing health. I think that women should look at wellness. I work with a group that did a study of Black people in California. One thing that came out is there is a high awareness and focus on wellness, meditation, supplements, proper diet, nutrition, getting your sleep. I don't know if we as the Blacks in our country look at ourselves as having that focus. Sometimes it seems like, a white middle class suburban type of thing, but it isn't. So that was one of the surprises of this data. We have 3,000, one of the largest studies ever for general health and wellness of African Americans. So I think do focus on wellness. There's a simple statement made by Nadine Burghardt, the past Surgeon General of California. She said, self-care is not selfish. And it's more men that need to hear that. A lot of women are saying, yeah, I get it, doc. I get it. So I'll take a bath when I come home at night, or just take it easy. My wife has to push me in the bathtub to have a relaxing bath. But she'll get in there all the time. So I think that concept of wellness, I think it's very important to get an annual evaluation in terms of getting your physical. I think, and focus on the obvious things again for women to me, breast cancer screening, cervical cancer screening, colorectal cancer, though that's both males and females, but that's the second leading cause of death for cancer is colorectal, number one being breast. So these things are some of the things that I think should occur with women. The other thing is, some things that women do well is to have your support group. So when you talk to your sisters, your friends, your family, talk about health and be very, upfront about it. Hey, I don't like going to mammogram. Let's push on my breast and I don't need radiation and whatever. Say, look, you need to go. Okay. And have those conversations amongst yourselves.
And I'm glad you brought that up, because we are in Breast Cancer Awareness Month. I'm wearing my pink today. And at 41 years old, I went and got my first mammogram last year, and I was mortified. But one thing that I see a lot of women my age, I'm seeing women younger than me being diagnosed with breast cancer. So much so as young as 31, 32 years old. What can we do when it comes to breast cancer and things of that nature that are common in Black women to really educate our communities about the importance of early detection and care?
So first of all, have a good family or your own personal doctor. When I'm down south with my family, so how is cousin Ann doing? Well, Dr. Winfield said. They don't say the doctor said. So when there's the conversation about health, I want people to feel connected to their own personal physician who knows them. Number two, no, like you're 41. The statistics are dirt. Yes, what is they? When it 2 days yesterday, the LA Chargers came here to promote breast cancer screening because there's a concept called, is what this is, crucial catch, where the NFL is now focusing on cancer screening, and one of them is breast cancer screening. So there are 7 different recommendations for screening for breast cancer. So it gets tricky. You technically at 40 or not 41 are not necessarily indicated to get screened, but there are some, like American Cancer Society, I believe, says you should. So have a doctor that you can talk to things about this. You saying, I was mortified, but I did it. Theoretically, now you got to talk to someone, each one teach one, that is 41 or 51, or let's say 50, the standard for sure. Everyone 50, every woman 50 or above should be screened at least annually. Just, have an age, did you get your mammal, man? You just knock that thing out, knock it out in the day, you're done. I want to do that. You tell them, look, you need to do it. However you would communicate it in your own way that I feel would get the point across. So that is one thing I would say. And I don't know, it needs to be normalized. It needs to be just part of what we do. I mean, as a guy, the last thing you want to do is get a prostate exam. The prostate exam involves what's called a DRE, a digital rectal exam. You can't just do a PSA. You got to actually feel the size of the prostate. So a lot of guys, I'm not letting that man put that finger in me like that. I tell them, they can put anything in there they want so long as it diagnoses cancer and keeps me alive. So, it needs to be spoken in the manner in which it is received, and ultimately you get the result that you need.
Well, I know we've been speaking about affordable health care and women's health, but we also have another target audience for our community, and that's our African-American children. And so what are some healthcare priorities that we need to focus on for our children?
Well, right now it's interesting. Right now, for me, the rate of children getting the COVID-19 vaccine is very low for a number of reasons. And with African Americans, it's the lowest. Primarily, the feelings that children don't get COVID. If they get it, they don't get sick. It's a new vaccine, and they already get all these other shots anyway. But I will tell you that children do get COVID. Children die from COVID. Children get long COVID, and children can give it to mama, grandmama, papa, grandpapa. So I really do feel that we need to get our children vaccinated against COVID-19. Without that population, we really can't put it at bay. There's like to just kind of hanging out there. The highest rates in the seniors, and then it kind of incrementally goes down. The lowest rates with our children. Secondarily, after you look at that, I think the concepts of behavioral health are very important. There's something called adverse childhood experiences. If children experience adverse events, homelessness, domestic violence, things along that nature, divorce, arguing with the parents. Studies show that they have worse health outcomes as they get older. So we need to be screening our children for these adverse childhood events, and then referring them to therapy or whatever it takes to fix the particular issue that was ongoing. Children should get an exam every year. As a pediatrician, one thing I find is often children have poor vision. They need glasses. Mm-hmm. If you need glasses, you can't read, you can't see the board, you can't learn. So once you get into school, you don't do as well. They may have other issues, ADHD. So we screen for that as pediatricians. I would say I will start with that, but I guess there's just a myriad of things that happen as it relates to children. As it gets up to adolescence, you have the teens. So the teens need sex ed, sexual education. So especially say a lot of times the girls / young women may not really know their bodies as well as they should, and need to, understand well. They need to be able to feel comfortable saying no. They need to understand that, again, now they need to be very focused on birth control, because if they do happen to get pregnant, they may have a hard time terminating that pregnancy. They also therefore need to know their options. And there's the Plan B pill that's still out there. So it changes based on age. And then again, as you mentioned, the children, you can't, as a pediatrician, I link the child to the family. So if you can ensure a strong family unit by, again, addressing social determinants of health. Does this mother have problems with daycare? So the daycare that this child is in is suboptimal. Can we get them in a better daycare? So mother having to get the child out of school early because of childcare issues. Does work, is a factor because she can't take off sick? So all of these things I kind of link. It's hard to separate the mother or the family from the child. But those things that I mentioned are kind of where I would start as it relates to children or child health.
Well, Dr. Brooks, you had mentioned COVID, and as I said earlier in the program, we have National Council of Negro Women. We have 5 health targets that focus on primarily African-American women and their children: HIV/AIDS, breast cancer, mental and maternal health, affordable health care. But we also have a COVID subgroup, which Dr. Elgin, she'll ask a question in a minute, but she chairs the COVID portion of that. And we want to know, how has ACA worked for those that have had COVID and long-term COVID?
ACA, mean the Affordable Care Act?
Yes.
Yeah. So again, I just have to underscore that we had Medicare in 1964. And the greatest step forward was, and then we know what, it was 2011. I can tell you now it's when it passed. But the greatest step forward was the ACA. ACA mandated electronic health records, for example. That's why you see everyone with it. So what the ACA just did is it just made healthcare more, it's not so much affordable, but available. So access is the absolute key to the benefit from that. And then the relative concept of having to have these healthcare exchanges, so people had the ability to go spend some money and get healthcare before, and then no underlying conditions. So it leveled the playing field. So there are a lot of things that came out of that. So all of those things directly related to the ACA. That's how the ACA had a direct effect there.
Good evening, Dr. Brooks. This is Dr. Elgin. I just had a couple of questions that I wanted to ask. And one is, I believe you were with us when we started talking about long haulers back last year in December. And I kind of foretold what everyone is talking about now, and that was with minorities in particular. Those subtle signs and symptoms will be ignored by our primary care physicians as something that is an innocuous kind of sign and symptom, and they're okay and they're fine. But fast forward from December to now, where do you think we are as it relates to access to individuals that need that health care for their long hauler syndrome? And what do you think are the next steps for people that have long haulers in our community?
You're right about African Americans in general. When we present for care, our symptoms are not addressed as readily. This happened during COVID, where there were cases where African Americans would come in with every symptom of COVID we knew, and they'd say, "You have bronchitis." And there was someone not African American would come in, I think I have a cold, and get tested and treated. The same thing with the symptoms. They just get dismissed. I don't have a lot of data on that, but anecdotally I've heard that. Number two is we're just getting our hands around long COVID in terms of really starting to understand it. Feelings it may be an inflammatory condition that happens after you get COVID. But there are now developing centers that are looking at having long COVID patients, and often in academic centers, let's say UCLA or University of Texas, University of Penn Medical Center. Individuals that seem to get access to these type of studies or treatments do not seem to be us. Those that run them are generally not us. Those that are staffing these are generally not us. And that's just the kind of the background of the racism that is part and parcel of the American health care system. So I don't, again, have a lot of data on that. So again, I'm speaking anecdotally. There may be data on that, and you're making me real curious to go look it up and find out exactly what is going on in that area. But I do have significant concerns. Also add to the equation that we were more likely to get COVID early on. So just by percentages, if 5% of people get long COVID, since we were getting more COVID, we're going to get more long COVID.
Right.
And if there are links to social determinants of health, which the studies again show, social determinants of health have more of an effect on your health than access to healthcare, money, education, etc. And racism is an independent factor in healthcare outcomes.
Yeah.
Studies show that the same person with the same job, same education, same healthcare has a worse health outcome. So the only variable is race. So when you start to think of all of those things, then you think of something that's kind of non-specific and not clear to understand, like long COVID, you're really going to see likely racial biases. I just been having headaches. I got COVID 3 months ago. I have a headache and I just don't feel well. Well, you just must not be taking care of yourself. Well, go have your doctor do a physical and come back and talk to you. Someone else comes in, let's put you in this study.
Yeah.
And we'll monitor you and see what we can do for you and come up, get some data, and then maybe have some new treatments, some experimental approaches. Generally speaking, that's just not us.
Right.
So I think that it is a significant concern. And for me, I am more concerned about long COVID than I call it short COVID or acute COVID. Most people that are vaccinated, almost all people that are vaccinated are not in the hospital and dying. And vaccination seems to reduce your chance of getting long COVID. But long COVID is the real problem. And you get past that, your coughing and your fever and your weakness, and 2 weeks later, you're fine. That thing that happens 2 months, 3 months, 8 months down the line is the primary concern. That's what I tell our people when I get a little pushback on getting vaccinated.
Right. Right. And you mentioned, one topic that is like a very important topic is research, particularly in our community. And we're not going to learn a lot about COVID because for us, we don't want to be involved in the process of research. So it's a vicious circle of we're not being taken care of, but we're not going through the research to be involved in those research studies, but we're not being taken care of. So what are your thoughts about our community still not trusting the medical community related to being involved in research?
All right, so that's a great question. So first of all, with the two main vaccines, the Pfizer and the Moderna, they strived to get African Americans in the clinical trials, and they succeeded. We were about 10 to 12% of the clients in the clinical trials for both those vaccines. So that was excellent. The National Medical Association had a project called Project Impact, Increase Minority Participation in Clinical Trials. We realized, and we do realize now, that it is imperative to get African Americans in these clinical trials because there are mild or major variations in how African Americans respond to certain therapies. generally probably not genetic, but based on just determinants of health and our physical bodies, maybe more high blood pressure, more obesity, whatever. So what we were hearing during COVID, as you heard, was the U.S. Public Health Service experiments on Black men with syphilis. And just as a sidebar, we are not saying the Tuskegee experiment anymore, because it starts to disparage Tuskegee Institute. Tuskegee was not the issue, it was U.S. Public Health Service. So I let them know that we need to be in these clinical trials. There are now manners in which there has to be research that is done and consent that is obtained prior to putting you in research trials. I will say also that I am feeling and hearing and noting that the researchers actually want us in now. It's kind of been pointed out that your study is only 2% African Americans, and it starts to make their data not quite as strong. So now that we are now in this DEI, diversity, equity, and inclusion realm that has come from 2019, 2020 with the police killings, that there's more of an awareness of the need for diversity in clinical trials. So as African-American doctors or healthcare providers, we have to talk to our community and let them know, I don't want to hear the guinea. I don't want to be a guinea pig. I don't want to hear that. We need to be in these clinical trials, and they need to hear it from us, from you, from me, from the National American Association. Again, you National Council of Negro Women, even the National Bar Association, not just medical groups, other groups, NAACP, Urban League, because we have to work together. We all have a common goal of uplifting our people on all levels.
Well, now I'm intrigued to talk a little bit more about healthcare disparities. So just a short story, in working on my doctoral thesis, my first one was healthcare disparities in Black children. And in doing my research, it was a year-long literature review that I did that at the time, there wasn't any studies about our Black children related to globally 0 to 12. How are they treating our children? There was more information about the numbers related to how children that don't look like us were treated than there was about Black children and other minority populations. So out of that, I got that there was no, the only numbers that I was able to research was how African Americans and Hispanic Americans, they usually use the emergency room because they didn't have a primary healthcare provider. They didn't have a primary healthcare provider because either of the language barrier or because of cultural incompetency. And you had those families that did not trust their primary care provider, or you had numbers that did not include our Black children. So the numbers were skewed related to healthcare and our kiddos. So my question to you is, what type of charge would you give us at NCNW related to healthcare disparities in children? Because when we talk about healthcare disparities, it is assumed that we're talking about adults, but we really have to start the conversation about having healthcare disparities in our Black children, our Black and brown children. So what are your thoughts on that? So
first, you're right. African-American children have higher rates of asthma. There are studies that show that 75% of Black families live within 20 miles of an area considered having poor air. You will see more asthma as people are in more crowded conditions, more people living in 5 people in a 1-bedroom apartment, just by spreading viruses, which can trigger asthma attacks. they're having dust mites in the mattress, but they can't afford to get a new mattress. So we need to address the social determinants of health. I'll get back to something that I said earlier. So there is more access than I think we believe. So like I work at a fairly qualified health center. So we provide care for those with Medicaid, Medi-Cal, uninsured, or even those that are right above poverty, so they can get paid for one of the health exchanges. Go to those places. Go get yourself a doctor. Spend the energy to find someone that you care for, that you think you would relate to. So talk to your friends. I got a good doctor. You need to see Dr. Vincent over there at Metropolitan Clinic. So do take that as an important action that one should take. Advocate for yourself. If you're not feeling that you're getting the care for your child that is needed, say, I want you to take another look, or I believe that there is more to it than what you're telling me. Invest energy in the schools. The schools have to do an IEP, individualized educational program for those children that are theoretically falling behind or not learning well. So there are a lot of resources in the school districts. Some school districts, many of them have school-based health centers or wellness centers. Utilize that. Look around you to find what the resources are that you may avail yourself of. Just care, really, and don't take no for an answer. I remember during COVID, I would just tell people, go in, just don't take no for an answer. Just get what you need and don't walk out of there until you get what you need. But it is complex because it deals with, again, the family structure. With the child, it is the mother primarily, but the rest of the family. But then also recognize that there are issues. So teenagers, by definition, are going to have things going on in their head. So
Right.
Talk to your child. Be frank with them. Look them in the eye. They can handle more than you think they can handle.
Right. Right.
And have high expectations for them as they are not dealing with disparities. So in other words, I think these are the things, and some of it all ultimately gets down to forget what those other people are doing. I know what I want from my child. Other people have low expectations for your child, perhaps if they're in the school. I've had how many friends I know that are adopters where someone told them when they're in high school, college, you'll never be a doctor. You need to change your major. So have that high expectation as a parent for your child.
Okay, so I'm gonna kind of put you on the spot because we have an awesome opportunity to talk about what the next steps should be for NCMW healthcare equity. And our executive director, Sister Janice Mathis, if you had to talk to Sister Mathis and you had the opportunity to say, you need to work on these 3 top things in health equity for Black and Brown people, what would those 3 priorities be?
Okay, that's really tough because first of all, I do appreciate the work that you all are doing right now.
Thank you.
So I think it would be behavioral health, mental health. I just think that is so important. It leads to so many other issues. If I were thinking more on the clinical level, I really believe a focus on obesity/diabetes. Crucially important. We have higher rates of obesity and diabetes, and they're proportional, they're linked directly. A lot of that, there's some studies that shows you have for behavioral health, you may eat away your problems, so that those things may be linked. And clinically speaking, I also think a major one is hypertension. But in my mind, I feel like there's something else out there. I mean, behavioral health is behavioral. For the medical, clinical, it has to be, right now anyway, diabetes/obesity. I guess the third thing would be, and I don't know exactly how to frame it, but it would be the social determinants of health. I think that we need to get that information out there, that how important that is on your overall health. So if I had to, put it right now, whatever time it is today, it would be a general focus on behavioral health, diabetes / obesity, and then the social determinants of health, and put in there racism, because we have to understand the effect of racism and ways to address it, and understand that racism under social determinants of health it needs to be there, because it's almost like not really a social determinant of health. It is like a visual, I don't know, because race is all visual. You put people in a room, you took blood from them, you couldn't take 10 blood samples, you couldn't tell which one came from a Black person or a Latin person or a white person. So it's a social construct. So understanding the social construct of racism, and then how it affects those social determinants of health, that's that bucket there. And then the other two, as I mentioned.
Okay. What about, so to break it down just really simply in talking about social determinants of health, how would we do that? How would
So,
we down to our communities?
well, understand it, work hard on getting, again, a lot of it gets down to advocacy. So 20%, I believe, was the number of African Americans live in a food desert. Okay, so I'm a big believer in good nutrition. And good nutrition is eating well, but also just understanding concept of eating. That turn the television off and talk to each other. Something simple like that. Understanding when you look at a plate, you'd have a lot of vegetables, not a lot of starch, and not a whole lot of meat. So just that would be one. I think that's a major one, because obviously that leads over into diabetes / obesity. Workforce, trying to find ways to reduce stress, because we often are stressed at work. We might work in a majority company where we constantly feel microaggressions, and getting that increases your blood pressure, which increases adrenaline, and then that increases your blood pressure and your blood sugar. Work on areas such as transportation. People have issues with transportation. More mass transit, it's better for us. So a lot of it, like social determinants, tend to not be, some of it's personalized, but a lot of it is local politics. Think globally, act locally, maybe get politically involved. But have an understanding of how these things do affect you. And so those are some of the down-to-earth, day-to-day activities that I would have people address as it relates to social determinants of health. But you mentioned the studies. That the Journal of the National Medical Association has a lot of data that gives you information on minorities, statistics on African Americans in a lot of different areas, including SDOH.
Well, thank you so much for your wisdom on a lot of things related to healthcare equity. One thing that I would love to see us partner on is discussing how we can get in our community, how research is so very important, and participating in research is so essential. So I would love to work with you on that. And I would love to see some tangible things come out of that collaboration. But without any further ado, I would like to turn it over to our illustrious leader, Sister Janice Mathis.
Well, good evening, everyone. And thank you so much, Dr. Elgin and Ms. Denton, for this opportunity. And thank you, Dr. Brooks, for your expertise and for your generosity of spirit to share it with us this evening. I learned a lot, and I'm sure that the audience did too. And even if it reinforces what they already knew, that's always a good thing as well, because health really is a journey. Some days I track my steps and watch my vegetables and my water, and some days I don't. But I try to make it more often than not that we do the things that we ought to do, and having that reinforcement certainly is helpful. So we thank you for that. And I thank this amazing committee led by Shara Denton and Dr. Angelia Elgin for your consistency, but also for your innovative spirit in approaching this issue of health equity. Every time I think about the social determinants of health, I said, oh my goodness, which one? Which one? Everything we encounter, from how we fuel our homes and how we heat our homes. In Georgia, I know that when I lived there, there was a problem with burning coal, and that you could track the asthma rates based on how close they were to a coal burning plant. And so everything matters. And then you talk about the workplace. What about those whose work is marginal or underpaid? We observed earlier, well, I guess it was last month now, Black Women's Equal Pay Day, which should be Black Women's Unequal Pay Day, along with the disparities in wages and working conditions. For those who are financially insecure, that creates a certain kind of stress all by itself. And so often women, not always, but often women are carrying the dual burden of being the breadwinner, the head of household, and the nurturer. And it's a lot. That parenting is designed to be a two-person job by definition, but often it is not. And so it seems that on every side, there's something to be addressed. But I'm here tonight really to say, don't give up hope, because I think, and the more I think about it, that hope is a social determinant of health. And when children and families don't have hope for a brighter day, when grandparents can't look into the future and imagine that the grandchildren are better off than they are, that sense of lack of agency over your own body, your own destiny, your own future surely has an impact on our health. But be not discouraged. Look at the Affordable Care Act. How many times did the opposition attempt to kill it or put it out of existence? But the people demand it. The people know in their hearts and in their minds that healthcare is a fundamental human right. And so they would not let the Affordable Care Act be diminished. It wasn't so much what the Congress did, but what the people demanded through their votes and their advocacy. So I want to thank you all for tonight. Thank you for the reminder. Thank you for the inspiration. We've got lots of events coming up. You see, I've got my t-shirt on because I've been spending a lot of time out on the Maryland Eastern Shore, working with a delightful community in Cambridge, Maryland, to boost the voter turnout there. We're going up to Annapolis for a rally. In December, we will have our 60th National Convention in Washington at the Washington Hilton. So there's lots going on at NCNW. Check out NCNW at ncnw.org. We're sure that you will find something there. I saw Mrs. Moss from Good Health Wins. So I know that she's paying close attention to this discussion, as we all should. Once again, Dr. Brooks, thank you for sharing your expertise and for having the spirit to come out and share. We appreciate that.
Well, my pleasure.
What makes Morehouse such a special place.
Right.
At this point, I will turn it back to our able hosts, Dr. Elgin and Ms. Denton. The floor is now yours, and thank you for the opportunity to say a few words.
Thank you, thank you, Janice, as always, your support of this committee and all the things that we're doing on a national level. And thank you, Dr. Brooks, for your time and your expertise as well. Before we close out, we did want to give some people, those of you that are on Facebook Live or in the login for the Zoom, a couple of minutes to possibly send in your questions if you have any. We don't have a whole lot of time, but we want to be able to get some of the questions in there. And as we do that, then I'll hand it back to my co-chair, Dr. Elgin.
I just wanted to quickly again thank my chair, Sister Denton, Dr. Brooks. I want to thank those that are behind the scenes that's making this happen. But most importantly, I want to thank Sister Mathis for her support of our committee, as well as giving us the wherewithal and the encouragement to continue, even when it comes at a time, sometimes it's like, how are we going to possibly provide all of this healthcare information related to health equity? And because of her leadership and because of Sister Denton's leadership, we have been able to provide a lot of different opportunities to give information to our communities. So there are three events that'll be coming up that we would really like you to get the word out. We have a breast cancer awareness webinar in which we will have some of our NCNW breast cancer survivors that will be speaking, and that's on October 26th at 8 p.m. Eastern Standard Time. Then on the 20th, which is actually next week, on October 20th, we have a discussion about long haulers and where we are today with research and the importance of research in COVID. And that is on the October 20th at 8 p.m. Eastern Standard Time. And then lastly, we have World AIDS Day that will be on December 1st. And that will be our last webinar of the year. So we want to turn it over for questions. Are there any questions for Dr. Brooks?
And we also want to, and Dr. Brooks, you did mention, I'm sorry, Dr. Elgin, didn't mean to cut you off. Okay. You had talked about emotional wealth. We also have an emotional health as wealth seminar on October 27th at 7 p.m. And that is something that the national headquarters has also put in place because they did see the gap in that with our communities, the taking time for emotional health as wealth and just focusing on that aspect of our health, because you don't hear about it a whole lot in our community. So that's one thing the national headquarters has put in place. I would like to say about 2 years now that's been in place, especially since COVID. So you did speak briefly on that. And so we thank you for that as well, because it all ties in together. Every part of health plays a part in longevity of our lives. So thank you both for all that you have done. And from what I understand, we do not have any questions. So we thank you for your time. And we also want to recognize our National Program Chair, Ms. Paulette Norvell-Lewis from Georgia. I had to be a little biased right there. She's also on the call. So thank you, Ms. Paulette, for your encouragement, your support of this committee and us individually. Did you have any words that you would like to say, Ms. Paulette?
I just want to congratulate you and the committee for the wonderful work that you've been doing. And I really ditto everything Ms. Mathis said and Dr. Brooks about the social determinants. I think we need to hone in a little bit more on that. One of the things I used to say when I was working was financial health impacts physical health and physical health impacts financial health. And all of that has an impact on our diet, our homes, our housing. All of that brings stability and wellness to our families. So I think we're on the right track, but obviously we have a whole lot to do. Again, thank you for this wonderful effort and for the information that you've been providing to all of our membership and to those who joined us this evening.
Thank you, Sister Paulette. And I want to thank my co-chair, Dr. Elgin. And again, thank you, Ms. Mathis and Dr. Oliver Brooks for your time. We have thoroughly enjoyed you on the sessions that you've been a part of with the National Council of Negro Women. So with that being said, I want to wish you all a good night and just continue to listen out for our future events for health equity. Thank you.
Thank you. Thank you for having me.